Bismillahirrahmanirrahim. Assalamu alaikum. I hope you all are doing fine and taking good care of your family, especially elders. We are starting a new topic today. The topic that we are going to study today is novel GIT drug delivery system. In today's class, we will be learning about the introduction to the novel GIT drug delivery system, background to the study and biopharmaceutical classification system, relationship between oral dosage form and its effects, gastrointestinal anatomy and dynamics that is important to study in order to understand the formulation of GIT drug delivery system, and the novel approaches for GIT drug delivery. So let's start with the introduction first, or the background to study the novel GIT drug delivery system. In view of the recent advancements in a time of augmented remarks to the efficiency and safety of the medicines embedded in dosage forms, it seems as important as ever to study the pharmaceutical concept of the safety and efficacy of formulations in different aspects that is a prerequisite for a successful pharmacotherapy. Despite tremendous advancements in drug delivery, oral administration of therapeutic agents still remains the favored route of majority of clinical applications. Due to the excellent accessibility and patient compliance, as well as the preferred alternative route for drug administration for the non-invasive drugs, among the other various routes, it is still a preferable route of administration for the delivery of drugs. Although there have been several limitations in oral administration of drugs, like non-uniform drug absorption profiles, incomplete drug release, shorter residence time of dosage forms in absorption window, and a lot many more to systemic circulation, it has come a long way. Now it has turned toward modifying and manipulating oral dosage forms to exploit from different conditions of the gastrointestinal tract for drug delivery in various ways. In view of the fact that correlation between drug intake and a clinical response is complex enough, the choice and design of the ideal pharmaceutical dosage form of a drug delivery system would be critically important to reach a progress in superior drug development. Variations between drug response within individuals could be attributed either to the product bioavailability, like the rate and extent of drug absorption, drug pharmacokinetics, which includes metabolism, distribution, and elimination of drugs, or the particular concentration effect relationships, which in turn could potentially be influenced through a mixture of intrinsic and extrinsic variables. Before starting further, it is important to know that how the drugs are classified. FDA classifies drug with the name Biopharmaceutical Classification System into 4 classes, that is BCS Class 1, BCS Class 2, Class 3 and Class 4. With reference to the BCS, drugs have been categorized in terms of their solubility and intestinal permeability in these 4 groups. Drugs that are classified in class 1 are supposed to be well absorbed when taken orally due to their high solubility and high permeability characteristics. Whereas all the drugs from class 2 to class 4 suffer from either low solubility or low permeability, or in case of class 4, both low solubility and low permeability. This would present challenges to the drug developments. Drugs that are classified into low solubility groups keep drug absorption via GI tract as a limiting factor for reaching the suitable blood levels in order to produce a therapeutic response. This is the schematic representation of the relationship between oral dosage forms of drug and its ultimate effect. So whenever a drug is taken orally, it gets disintegrated and proceeds for dissolution. Once the dissolution is done, diffusion through GI fluids is carried out and the drug reaches to the membrane. Here the uptake into the blood or lymph took place and the drug reaches to the systemic circulation. When the drug reaches to the systemic circulation, either it is in bound form or unbound form. When it is in unbound form, it could be a free tissue drug concentration or a bound tissue drug concentration. In unbound form, it reaches to the active site where it produces a therapeutic response. Meanwhile, from unbound form to the passage to the active site, it may be cleared off. There are other factors which are responsible for the loss of drug that are between the drug and disintegration and dissolution to the diffusion through GI fluids. The loss can be carried out via luminal degradation, and when the drug is passing through from diffusion through GI fluids to the membrane, the loss can be due to mucosal metabolism, and when from the membrane to the uptake into the blood of lymph, the loss of drug can be due to hepatic metabolism. So let's review it again. As far as as we know, the absorption of drugs from intake, for example, oral drug delivery system to its site of action is a complex process, or more accurately, a combination or succession of complicated processes. See here, when a drug is taken orally, and it would produce its effect, a therapeutic response to a particular site, but it is carried out by a series of complex processes. After oral administration, drug leaves the formulation and dissolves in the aqueous digestive fluids. It reaches and crosses the GI mucosal membrane before passing into the blood, moving along the GI tract with the luminal content at a variable speed. Once the drug is reached into the blood circulation, process of drug metabolism and elimination starts. Whilst it is also possible for some drugs that degradation or metabolism may occur sooner than the absorption is completed, leading for a decrease in drug efficiency. In general, absorption of drugs through GI tract varies on account of many factors like nature and surface area of the GI mucosal membrane, varying from stomach to the rectum, as well as the physicochemical properties of the pharmaceutical dosage form along with the luminal content. Hence, a balance among the factors would have a notable effect on how much of the administered drug reaches to the bloodstream. That is summed up by the term bioavailability. Considering the pharmacokinetics and drug delivery, it is important to have a deep understanding of the biology and anatomy of the GI tract, as it is of substantial value for optimizing the bioavailability of orally administered drug. So let's see the gastrointestinal anatomy and its dynamics. Gastrointestinal tract is a group of organs joined in a long tube which is divided into several sections. Each of that fulfills a specific function. See here, the group of organs start from here and it ends up to the anus. The transit begins with the oral cavities, follows through the pharynx, esophagus, stomach, small intestine and large intestine, and ending with the rectum to anus. Each segment has certain morphological and physiological features, but there is almost a common structure for all parts of the GIT, with the muscular walls comprising of 4 different layers: inner mucosa, submucosa, muscularis externa and serosa. Here you can see a diagrammatic representation of the mucosal walls. This part is serosa, followed by the longitudinal muscles, circular muscles, submucosa and mucosal muscles, mucosa and epithelial lining, lymphoid tissues, mucosal glands and submucosal glands. For a complete elaboration of the anatomy and dynamics, I would be referring you to watch a video on YouTube. The link would be provided in this video's description. Stomach serves as the most primarily mixing area and a reservoir that secretes pepsinogen, gastric lipase, hydrochloric acid, and the intrinsic factor. The section of the GI tract is normally impermeable for absorption of most materials into the blood except water, ions, alcohol, and certain drugs such as aspirin. The stomach is composed of the following parts: fundus, body, the central part, and the antrum. The pylorus is an anatomical sphincter. This is the pylorus. It is an anatomical sphincter situated between the most terminal antrum and the duodenum. The motility of the stomach differs between the fasted and the fed state. The motoric activity in the fasting state is termed as interdigestive myoelectric motor complex. In simpler way, we say that IMMC. It is a 2-hour cycle of peristaltic activity that is generated in the stomach and progresses towards the ileocecal junction. The main aim of this IMMC is to clear the stomach and the small intestine of indigested residues, solons, saliva, and sloughed epithelial cells. The IMMC is composed of 4 phases. The first phase lasts for about 45 to 60 minutes with a few or no contractions. The second phase consists of intermittent, irregular, sweeping contractions, and it involves the secretion of bile and lasts until the intensive peristaltic contractions of the third phase starts. The peristaltic waves of the third phase, also called as the housekeeper waves, last for about 5 to 15 minutes and decreases gradually in the fourth phase to prepare the stomach for the next cycle. Following meals, food is stored in the upper part of the stomach, and approximately 5 to 10 minutes after food ingestion, the stomach motor activity starts and persists as long as the food exists in the stomach for around 2 to 4 hours. The peristaltic contractions of the proximal stomach slowly compress the food towards the pyloric sphincter. Here you can see that the pyloric sphincter. The peristaltic contractions would slowly compress the food towards the pyloric sphincter, and the stomach contents are evacuated into the duodenum. The pyloric sphincter causes an appreciable contractions of the lumen at the gastrointestinal junctions. The next part of the GI tract is the small intestine. The content of the stomach follows the small intestine, the major absorptive and digestive site of the GI tract, providing an extended surface area by the circular folds of about 10 mm height through the microvilli on the absorptive cells of the mucosa. Small intestine follows the large intestine. The last part of the GI tract is the large intestine, extending from the ileum to the anus, with 1.5 meter long and 6.35 centimeter in diameter, serving mainly as the fecal storage and water absorptive roles. It is significant that no enzymes are secreted in the mucosa, and the last stage of digestion is primarily conducted by the resident bacteria. Not surprisingly, these anatomical and physiological parameters of the GI tract remarkably affect the rate and level of the drug absorption, and they should be assessed before designing a new drug formulation. There are several difficulties and rules in designing controlled release systems that are to be considered for the better absorption and enhanced bioavailability of drugs embedded in the oral administered dosage forms. One principal requisite for the successful performance of orally administered drug is that the drug should have good absorption throughout the GI tract to certify continuous absorption of the released drug. Regarding the BCS classification of drugs, this could be a major constraint in oral controlled drug delivery system, that not all the drugs are evenly absorbed throughout the GI tract. Seeing that most of the orally administered drugs display region-specific absorption that could be related to differential drug solubility and stability in different regions of the GI tract as a result of changes in environmental pH, degradation by enzymes present in the lumen of the intestine, or interaction with endogenous compounds that is shown in this table. So here in this table you can see that different sections of the GI tract are presented over here with their lengths and diameter and the specific pH and major constituents and transit times. So let's start with the oral cavity. Oral cavity has a length of 15 to 20 centimeter with a diameter of 10 centimeter. The pH in oral cavity is from about 5.2 to 6.8. And the major constituents that are present in oral cavity are the enzymes like amylase, maltase, thiolane, mucins. And the transit time in oral cavity is short. The second part is esophagus with a length of 25 centimeter with 2.5 centimeter in diameter and a pH of 5 to 6. There are no any constituents present in esophagus, and the transit time is very short. The next part of the GI tract is the stomach, and its length is 20 centimeter and diameter is about 15 centimeter. It has a slightly acidic pH and it is from 1.2 to 3.5. The major constituents that are present in stomach are hydrochloric acid, pepsin, renin, lipase, and intrinsic factor. The transit time from stomach is from 0.25 hours to 3 hours. Stomach is followed by the small intestine, and the first part of small intestine is duodenum. Duodenum is 25 centimeter in length with a diameter of about 5 centimeter, having a pH of 4.6 to 6 the major constituents that are secreted in the small intestine or are present in the small intestine are bile, trypsin, chymotrypsin, amylase, maltase, lipase, nuclease, and cytochrome P3A4. The transit time of from duodenum is about 1 to 2 hours. Duodenum is followed by jejunum. Its length is 300 centimeter. The diameter is around 5 centimeter. And pH in this region is slightly higher, that is from 6.3 to 7.3. Amylase, maltase, lactase, sucrase, and cytochrome P3A5 are the major constituents in this part. The transit time is unknown in this region. Ileum is the next region which is present. The length of this region is again 300 centimeter. Diameter is 2.5 to 5 centimeter with a pH of 7.6. Its major constituents are lipase, nuclease, nucleotidase, and enterokinase. The transit time from ileum is from 1 to 10 hours. And here starts the large intestine. The first part of large intestine is cecum. Its length is around 10 to 30 centimeter. Diameter is 7 centimeter and a pH range of 7.5 to 8. There are no major constituents present in this part, but some of the bacteria do reside over here. The transit time from this region is short. The next region is colon. Colon is 150 centimeter in length with a diameter of 5 centimeter and pH range of 7.9 to 8. The transit time from this region is 4 to 20 hours. The last region is rectum, 15 to 19 centimeter in length, 2.5 centimeter in diameter, and pH is 7.5 to 8. And the transit time is variable. That means it differs from person to person, and it differs from the fasted and fed state as well. Drugs that are substrate to certain enzymes in particular region of the GI tract might have regional variability in their absorption along the GI tract. There are key points in designing a novel GIT dosage form. Number one, that I have already told you, that drugs that are substrate to certain enzymes in particular region of the GI tract might have regional variability in their absorption along the GI tract. One should consider this region-specific drug absorption concept for designing the ideal drug formulation. It has been widely accepted that about 90% of all the absorption of nutrients takes place in the small intestine, depending on the defining characteristics of the gastrointestinal fluids and membrane surface area at different locations. Consequently, transit time of a pharmaceutical dosage form through the GI tract would determine how long a drug will be in contact with the preferred absorptive region. The usual transit time of a drug formulation or for a nutrient to pass from the stomach to the ileocecal valve through the small intestine is around 3 hours. And transit time for colon is much longer, up to 20 hours or more. Subsequently, the time of a drug will have in its absorption site would be fairly short. More so if the drug is preferentially absorbed in the proximal small intestine rather than throughout the small intestine. Accordingly, a drug that is largely or solely absorbed from the upper GI tract would have variable bioavailability distressed by factors that changes the gastrointestinal transit. Gastrointestinal transit time of a drug formulation is the most limiting physiological factor in the development of oral delivery systems that might be altered by the physiological properties of the gastrointestinal transit time. The pattern of GI transit and gastric emptying depends on whether the person is in a fasted or fed state and the physical state of the drug delivery system, either it is a solid dosage form or a liquid dosage form. There are certain novel approaches for the gastrointestinal drug delivery, and we will be studying all of them. The first approach is prolongation of gastric retention, that is also known as gastric retention of drug delivery systems. This is further subdivided into two types of drug delivery systems, that are floating drug delivery systems and mucoadhesive drug delivery systems. There are many other approaches for gastro-retentive drug delivery system, but we will be mainly focusing on these two drug delivery systems. The other approach for the novel delivery of drugs into the GI tract is oral osmotic pumps. The initial osmotic drug delivery systems and the designing we have discussed in the previous semester. We will be more focused over here on the oral osmotic pumps only. pH controlled drug delivery systems can also be utilized in order to control the delivery of drug in the GI tract. Ion exchange controlled drug delivery system is another system of drug delivery or a novel approach to deliver drug into the GI tracts. So that's all for today's class. For questions and queries, a discussion forum is opened on HULMS. There is a trick behind listening to this lecture. Just listen to this lecture carefully, transcribe it in on a paper, and make a script and refer to the Encyclopedia of Pharmaceutical Technology. I would be sharing a link of that book in your HULMS. and then try to understand it. And still, if you find any difficulty in understanding any part of the lecture, ask questions in the discussion forum. That would be highly appreciated. Thank you for patiently listening to today's class. May Allah bless you and accept all your prayers in this holy month of Ramzan. We will be discussing gastroretentive drug delivery system in our next session. Allah Hafiz.